Welcome back. So we're now on case 2, but you'll notice this is Mr. B, same person as case 1, and it's 1 year later. So we're dispatched to his house this time at 8:44 in the morning. Again, an adult male, very short of breath. As we arrive at his house, we are met by his sister, and she's very anxious. She's trying to rush us right in. We walk in to find the patient in the kitchen, standing and holding the table, kind of a type of tripod position, although he's looking a little unstable as he's standing up. And he's got this neb machine kind of hanging out of his mouth, and it's an electric pump machine, so it's kind of noisy. We don't notice any wheezing this time as we come up to him and start our assessment. So the patient is alert and anxious. He is speaking with about 2-syllable dyspnea with a very soft voice. Kind of difficult to hear what he's saying. Breath sounds are auscultated and diminished to absent. In fact, we really felt that for the most part we couldn't hear any movement of air at all. His skin color probably best described as gray. He was kind of a bluish gray tone, a little perioral blueness, but mostly just a little grayer complexion. Asked him to sit down, and he didn't want to do it. He didn't want to move at all. He did have a pulse. It was present at the wrist, and it was both strong and fast. The thing that I kind of remember about this patient was how he seemed very anxious to get a shot to calm his nerves. It was what he was trying his hardest to get out, is I need you to give me a shot to calm my nerves. The history behind this is that the patient got upset with his brother when he was on the phone. In fact, they had a pretty good argument around midnight. And ever since hanging up, he had been notably short of breath. She was aware that he had been using his neb machine almost all of the last 8 hours, pretty continuously. So our physical assessment was pretty well just our primary. We noticed that he had a low O2 sat, which kind of goes along with the cyanosis. We noticed that he had shoulder and abdominal muscle use, particularly prolonged exhalation. He had a respiratory rate of about 28 that was quite short. The patient was finishing his neb as we arrived. We immediately placed him on 100% oxygen using a non-rebreather mask. We prepared to assist ventilations. We were as soon as we got the O2 on him, we started assembling a inline neb to put with a bag valve mask to help assist his breathing. And we thought that was probably going to be the most effective treatment, next to possibly giving him some epinephrine. And just as we were getting ready to start that, the patient collapsed. So now we have him on the floor. And as he's down on the floor, we notice that trying to get some ventilations into him, checking his airway, his jaw is locked up tight. We were able to get a nasal pharyngeal airway in, but oral airway was not going in right away. It took a little bit before we were able to finally squeeze one in. And we noticed, too, that with both of those attempts, he still had poor compliance with ventilations. We wanted to get an advanced airway in, and my partner made a couple of passes, tried to get a good visualization, but because his tongue and mouth were still pretty tight, they'd loosened up a little, but not very much. They were not good visualizations, and attempts were unsuccessful. A third attempt that I made, I noticed a lot of secretions were in there, and decided to just work on suctioning those out and then go back to bag valve mask ventilations. At this point, we also checked for a pulse, and he did have a radial pulse, which was notably slower than the first attempt. The fourth attempt for an endotracheal tube was good. He actually sucked that endotracheal tube right in. We had bilateral breath sounds, noticing they were slightly diminished on the right side. He still had a good deal of gastric distension from the time that we were ventilating without a advanced airway. and we wanted to get that epinephrine in, and now thought the best way to do that would be using the endotracheal route. Bear in mind that this was several years ago, and at that time, endotracheal epinephrine was considered almost as good as IV epinephrine. We applied the ECG, and this is our first cardiac monitor strip that we got. And you can kind of see there that he was already slowing into a bradycardic rhythm. We got an IV in fairly quickly after that. Atropine, 1 milligram was given. Now you might think, since he's got a pulse, that 0.5 milligrams might be an appropriate dose, and that's true. At this point in time, we thought he was deteriorating pretty rapidly and thought that a milligram of atropine wasn't going to hurt anything. We also wanted to give him a little fluid, so he had a 250 cc bolus after that atropine. We were ventilating at a slightly accelerated rate. Part of our thinking there was we knew we were behind the 8 ball and getting oxygen in there, and also felt that we would probably be dealing with a pretty acidotic patient, and having a higher and faster ventilatory rate was probably not a bad deal. We also, however, had an endotracheal cuff leak, and at this point we checked for a pulse. He had one. It was weak, but he was still unresponsive and for the most part not moving air on his own. And you can see that his rhythm was changing. So now, having an IV, we decided we would go ahead and give him some epinephrine IV. We gave him a full milligram by slow IV push, and we reassessed the patient. He had no breath sounds. He had no gastric sounds. His cuff leak was getting worse. His pulse was getting stronger and faster. There was no jugular venous distension and no tracheal shift. We felt that with that situation, we were going to have to remove that endotracheal. We looked at the monitor real quick and saw that now we were getting a nice pulsatile rhythm. And sure enough, he did have a good pulse. So we moved him onto the backboard with the officer to assist. We got him onto our stretcher. Once there, we removed the endotracheal tube and went to reinsert. We were not able to pass the same size tube. He had an 8.0, and for some reason another 8.0 would just not go into that glottic opening. So we placed the 7.5, reassessed breath sounds, and noticed that they were again diminished to absent on the right side. We reassessed pulses, and this time found them to be absent. Because we determined that he was in ventricular fibrillation, we defibrillated. We gave 3 shocks, which was the protocol at the time. We were escalating in energy settings with our monophasic defibrillator, 200, 300, and 360. And on the last one, you can see that we successfully converted him to what looks like a flatline rhythm. So we continued our CPR. We gave another milligram IV after 3 minutes. We rolled him into our ambulance and transported with CPR in progress. Because he had been in VFib, we thought he would probably need an antiarrhythmic, but because he was now in asystole, we held off on that. We were assessing our effectiveness of CPR, and we were not able to determine if there were any pulses being produced by CPR at all. Ventilations were also becoming more difficult. My consideration at this point was I was worried that he might be developing a pneumothorax. He, however, had no jugular venous distension, and there was no tracheal shift. Another thing that's unique to this time frame when we were treating this gentleman was that high-dose epinephrine was considered another good option. High-dose epinephrine was shown to really give you cardiac rhythm back a lot quicker. However, it was dropped because it never really resulted in better cerebral blood flow and never shown to have any long-term effects of benefit in a cardiac arrest patient. But at that point in time, it was still our protocol, so the next dose of epinephrine was at a high dose. And again, we continued to give him some IV fluid wide open. After contacting medical control, they wanted us to go ahead and give him both the lidocaine and some bicarb. And so we gave both before attempting another shock. However, when we went to shock, we decided not to because this is what we saw on the monitor. It was a idioventricular rhythm, and we were hoping to see a pulses with that, but when we arrived, we did not detect any pulse at all, so we continued compressions. In the emergency department, Mr. B was found to be in a wide complex bradycardia, similar to what you just saw. He was easier to ventilate by this time, and breath sounds were recorded as equal. Then we reassessed breath sounds, so the emergency physician and a respiratory therapist both listened and said they felt that they were equal and that we were moving air well. We did not still have a pulse with compressions, and we were constantly changing out who was doing compressions and trying to maintain good CPR. We did get one ABG drawn, which we checked a little later, and this was the first ABG after arrival at the emergency room. If you look at these numbers, I hope that what you can notice is that we were very successful in oxygenating the patient, pretty successful in bagging down his CO2 level, and his pH, however, was still 7.15, so he was acidotic. We were not feeling pulses with compression, so we used the Doppler in the emergency department, and no pulses were detected from the Doppler. He then went into ventricular fibrillation, which he remained in despite future shocks. He went through a variety of medications, antiarrhythmics, including magnesium, beryllium tosylate, another dose of lidocaine. He had also received a total of 500 cc bolus of normal saline while in the emergency department, another dose of bicarb, and standard dose epinephrine every 5 minutes. We did notice after that CPR was starting to make pulses. We were moving some blood. However, looking at the ECG, it was in asystole. After 25 minutes of CPR in the emergency department and now in asystole, the patient was declared dead. So in reviewing this case, be thinking about how you would have managed the patient differently and what was the situation that caused a person who was in respiratory distress to go into cardiac arrest. Bear in mind that this is a patient with known asthma, with known COPD, and with known heart failure. So after you've listened to this, your next task would be to try our quiz, and invite you now to go ahead and go to case number 2 and answer these quiz questions.